Before we begin, we'd like to acknowledge that we are recording on the traditional country of the Kaurna people of the Adelaide Plains. We pay respects to elders past and present. We pass that respect to any Aboriginal or Torres Strait Islander listeners. Hello and welcome to From the Heart. I'm a heart parent and your host, Sami Glastonbury. This episode, I'm chatting to Dr Stephanie Perrier. Dr Perrier is a paediatric and congenital cardiac surgeon at the Royal Children's Hospital in Melbourne. With over 10 years' experience in both France and Australia, she specialises in complex surgeries for babies and children, including heart transplants, congenital repairs, and the use of heart devices.
I love the anatomy. I love the heart. It's so magical, like to see that you can stop the heart and then restart the heart and the person will be fine. It's magic.
A very warm welcome to you, Dr Perrier, or if I may call you Stephanie.
Yeah, thanks, Sami. Thanks for the nice introduction.
It's an absolute honour to have you on From the Heart podcast. We appreciate that you're incredibly busy. And as I sit here tonight, Stephanie's in her scrubs. So very much obviously finished her rounds and surgical duties for the day. So again, thank you. So you joined the team at the Royal Children's Hospital 2 years ago. What brought you to Australia?
Previously, I was in France, but I had spent 2 years as a fellow at the end of my training here in Melbourne at the Royal Children's Hospital. And that's how I discovered the country, and I really loved the experience. And so when the opportunity to come back presented, I just jumped on. Yeah.
You thought to yourself, I've been there before, I've seen it, I love it, I'm going back.
Yes.
So Stephanie, was paediatric cardiac surgery always your focus? Was it always on the agenda?
So when I was in med school, I really wanted to I loved all the medical fields, but I realized that I needed something a bit more crafty and hands-on than just, medical thinking and trying to get a diagnosis and then trying medications. It was not enough for me. So I started my training as a surgeon. And in France, you don't start straight away into the specialty you want, or at least that was the case when I trained. A bit by chance, my first rotation was in cardiac surgery and I just loved it. It was adult cardiac surgery, but I loved the anatomy. I loved the heart. It's so magical, like to see that you can stop the heart and then restart the heart and the person will be fine. It's magic. I really loved the team I worked with at that time. And I think it was also a big incentive for me to have the right mentors at the right moment. So I tried, I did rotations in orthopedics, in general surgery. I did liver transplant, but yeah, I knew I wanted to do cardiac surgery. And then because I worked in that team and it was a big adult program, it was a small pediatric program and no one really was interested. And so by chance, again, I started to observe first in theater and then to assist and then to operate. And I just loved it. And again, it was a mix of having the right mentor and, being surrounded with people that would motivate me. And then also, seeing the kids thriving. It was, yeah.
Well, I love that you've just started off by saying it was the heart is magical. And even just you referring to exactly that, which the majority of the people listening are a part of our heart community. And it is the fact that the heart keeps us alive, but then we can stop it. We can operate on it, we can fix it, and we can bring it back. I love the fact, I don't think I've ever heard anyone refer to it as magical, but it is. I actually love that you've said that because I think I'm going to reframe that in my mind. And it sounds like you just found your place.
Yeah, I think so.
You said you did those obviously other rotations and you obviously kept coming back to the heart, and we're very grateful that you did. So what was it like to shift if you said you did the rotation in adults and then you started to see obviously what that looked like in pediatrics? Because you obviously come from a different lens to what we do as parents, is it almost a bit mind-blowing to sort of say, well, the heart looks this size and I can do this, but now you've got to take everything to a really microscopic size?
It's funny because it's a recurrent questions I'm being asked is that, oh, but this is so tiny. I must say I don't really realize it is so small. It is small, yes, but we do use magnifying loops when we operate. So what I actually see is much bigger than what you think because it's being magnified, and we need that to be very precise when we operate. I don't know. Besides my job, I also have a life and I like, crafts and knitting and sewing and it's a bit the same. There's a famous French surgeon who was a pioneer in surgical innovation, and he was the first to describe surgical suturing techniques. And he did that because he witnessed his mentors being unable to save the French president who was victim of an assassination attempt.
Oh, wow. Okay.
And so his mentors were unable to save that president. And so he decided to spend, I think, a year or even more as an apprentice with his mother, who was embroideress. So she was embroidery and like sewing,
tapestry and
stuff like that. So, and he learned all the techniques, and then he applied these techniques to suturing of the vessels and suturing of human tissue. And that's still techniques that we use nowadays.
Wow.
And it all comes from, crafts.
Wow. I think you've reframed something in my mind. So that's fascinating. So you've finished your day. So talk us through what did today look like, or what does a day today look like for you? Because you're obviously a surgeon, you've got rounds, but then you also look like you participate in research. What does the day look like for you?
Yeah, well, I mean, every day is a bit different, but I can, for example, tell you about my day today. So I had to run after getting my daughter to daycare.
Yes, we've all been there. Yes.
And I arrived a bit late for the rounds, but I did the rounds in the intensive care unit and then in the ward. And then I went to theater, and I actually supervised my fellow for doing an operation. And then I catch up on all my op notes, and that's it. And then I call you, you call me.
And here we are. We're on a podcast. I love it. It started with childcare, some observing of surgery, some admin or paperwork, and a podcast.
Yeah.
Sounds very diverse. So is there a particular age group that you operate on? Like, obviously you're in a pediatric setting and that's your day-to-day, what today look like. Do you find that your surgeries are within a certain sort of, 0 to 5 or 0 to 10, or is it purely just by need?
Yeah, it's very broad. And yesterday I look after like a 60-kilo patient, and today it would be like a 6-kilo patient. So we have a 10 multiplier from one day to another. I would say the majority of the patients that we operate on are less than 1 year old, probably at least the half. So mostly babies. But yeah, we look after teenagers too, who have actually almost an adult, body size. So it's very broad, yes.
Okay, but mainly those little babies that we. So I'm here in Adelaide, so we send our babies across to you to fix. So if that's the day, so you said you started the day in doing your rounds in ICU.
Yes.
So would you necessarily start your rounds in ICU and then operate, or do you operate first up in the day, or what does that sort of look like?
Yeah, patients go to theater quite early in the morning, but then there is a first step in theater that is all the anesthetic start. So having the child to go to sleep, and then having all the anesthetic setup, all the monitoring placed, and that can take, an hour, maybe 2 hours. to get everything ready for us to really start the operation. So it leaves me time in the morning to see the patients and do the rounds, and how we are organized, that we work closely with the cardiology team and the medical doctors, so we can see the patients together. And it gives us, time to discuss patients and, share ideas and make sure we are on board with all the decisions that are being made. And then in the afternoon, I don't necessarily do a full round, but I review my patients of the day, or if there is, a specific patient that I want to review for any reason, I do. Sometimes I finish really late and I don't do it.
You can't. And so you touched on, Stephanie, that obviously our babies, as many would be listening, or those who are just starting their journey, they would know that they go in the hospital the day before for pre-operative, I should say. And then obviously they go in early, like you said, and you start off with that anesthesiology team. So who else is in the room? So as the sort of the theatre progresses over that time, who's in the room?
Yeah, there's many people involved in the care of a child who goes for a cardiac operation, and all of them are very important. So there are obviously doctors. So those are the anesthesiologist and the surgeon. There are junior doctors, so doctors that are, fully trained but still don't have much experience. And those can be anesthetic doctors or surgical doctors. And then nurses, theater nurses. And there's usually, when we are performing the operation, one nurse that is sterile and active on the field with us. And there's a nurse who's not sterile and is a link between the sterile table and the rest of the world, let's say. So she can open instruments for us if we need it.
Okay.
She can, transmit messages if we need to help us with, the communication in general, adjust the music, answer the phone. So they are, very important. There is a very important person who I think parents never see, is the perfusionist. The perfusionist is a specialized health worker who is responsible for driving the bypass machine. So the bypass machine, the heart-lung machine, is the machine that is going to basically sustain the life of the child when we are operating on the heart. So it's very, very important. And because we are operating, we cannot, make sure the machine is doing what we want the machine to do. And so we need someone who can run that machine, who can adjust, the speed and the pressure and the volume and the whole physiology. And they are actually, they are the person who keep the child alive, basically. So they are extremely important.
Incredibly important. So how many, if you had to do a rough count, how many people are in this room, in the theatre at the time?
I would say maybe 6 or 8.
Yeah, okay. So still pretty busy little area. And so for those listening tonight that maybe haven't gone on the journey yet, or they might have the diagnosis and they're waiting for surgery, could you talk us through the types of surgery? What are the most sort of common types of surgery that you perform?
Yeah. The most common heart defect is something that we call ventricular septal defect. It's basically an abnormal communication between both pumping chambers of the heart. So the normal heart has a pumping chamber on the right side that pumps the blue blood to the lungs, and a pumping chamber on the left side that pumps the red blood to the body. And normally these two chambers, they don't communicate with each other. And sometimes babies are born with a communication or a hole between these two pumps. So we have to go there and close the hole by suturing usually a patch around it. And that surgery most of the times happens in the first year of life. So that's the most common. Also, same type of I would say, problem that is abnormal communication, again, with the right and the left side, but at the level not of the pumping chambers, but the receiving chambers.
Mm-hmm.
When the blood, there is like a first story that just takes all the blood from the body, and the second story that pumps the blood. It's like a house.
It's like a house. And so when you say the patch, so you've obviously been talking craft and that learning of surgery and sutures and craft. So the patch that you're referring to, is there something that you're actually doing to reduce that hole? Is there something you're actually sewing in, or are you sewing together that septum?
Most of the time, so we can do, there's many techniques. I don't think we have time to go into that. Yeah, most of the time we use a piece of the bag that contains the heart. So the heart is naturally located within a bag that we call the pericardium, and we can take a piece of that bag and we can then sew that piece of tissue to the heart muscle, and that will cover the hole and close it.
And so you're taking a piece of the child's heart. So it's still something that's natural to that particular, that baby. Yeah. No, it's fascinating to think that at some point someone thought to do that.
Yeah.
Yeah, it's fascinating how obviously surgery evolves. So we obviously will have a lot of parents listening. Is there something, or is there a piece of advice that you think would be really beneficial for people to hear or understand about that are going on this journey? Because obviously it's incredibly foreign, it's daunting, it's overwhelming. Is there something that you share with some of those parents when you meet them before surgery?
Well, first I try to understand, not everybody wants to know all the details of the operation. So I think the first thing is to establish a good relationship with the parents and make sure we understand each other. And if, and then, if I see that they're asking more technical question, of course, I will go into details. But if I see that they may be already quite stressed and, there's certain things that maybe are not going to make any difference for them or may cause distress for them, I try not to go into too much details. But I think it's important to have a clear communication, and that if they have any question, we are always happy to answer all of them. There are no stupid questions. There are not obvious questions. Sometimes, some things are so obvious for us that we don't state it because for us it's just so clear in our minds, but in the parent's mind, maybe it's not. And so always ask all the questions that they may have. And then the other thing is that if you don't feel comfortable, if you don't feel that you have that trust, it's going to be very difficult to hand over your child for an operation. So make sure that you feel that comfort and you feel that trust. And if you don't, just keep asking questions and, keep the, communication until it's there. And then the last thing I think is, on the day of the operation, just try to think about something else. Sometimes the operation takes a long time because of the anesthetic setup that takes a long time. And then going back to ICU can take a long time. Sometimes the operation itself takes longer than what we thought because we want to adjust something, or just because, sometimes it's a bit longer than expected. And I can't imagine the parents waiting in the corridor and eating all the the nails.
Fingernails, yeah.
It's very hard. So I'd always say, just do something, whatever suits you. It can be going to the movies or going to see friends or family, or some people want to be alone, some people want to be surrounded, whatever suits you and whatever works, but just try to think about something else.
Something else, yeah.
The most difficult thing at that time, but yeah.
But I think the really lovely takeaway from what you've just shared there is ask the questions. Like you said, there's no silly question, and really take that that time or think about it ahead and write those questions down, and to know that you're there and more than willing to answer to whatever detail that the caregiver or the parent wants. I know in my personal case, I wanted all the details. My husband didn't want any details. And I'm not going to go into a few things, but I'll never forget I had done a lot of reading. And so everything that the surgeon was explaining to me, it was actually comforting for me that when they went through the detail in my mind, I thought, yes, I've read that. Yes, I understand that. It was almost like a tick box, and that brought me comfort. What I didn't realize is my husband hadn't read anything. And that level of detail did not tick boxes for him. But I love that, you're basically saying it's an opportunity, even if it seems like a insignificant thing. Definitely still just ask it. And I think even just what you're saying there around what to do while surgery is happening, I suppose, like you said, it's just whatever makes you feel comfortable, and know that it is a substantial amount of time. And I think it's funny if you said, like, I'm sure with yourself, you've started your day at childcare, you've done your rounds, you've done all this, you're doing a podcast now, you've filled probably a 12-hour day, but it's amazing. And I'll probably do the same. But it's amazing if you think about surgery, we literally think about it in the minute or the hour, and it can feel so incredibly long. But if you told someone to go do something for 6 hours or 5 hours or 8 hours, we could do it without blinking. So yeah, it is. It's a challenging time, but it's good to know that, speaking to yourself as a surgeon, that you want to hear from us. You want to hear from the parents. You want to be there to, like you said, form that trust and be there to answer those questions. So moving on to so we're kind of touching now onto the day of surgery. Do you ever say to the caregivers what to expect on the other side of surgery? Because obviously we hand over this, in our minds, perfect little baby, and then they come out looking very different.
Yeah. So when I meet with the parents before the operation, I detail the reason why we are doing the operation, what would be the, basic steps of the operation, and then what's going to happen after. And actually spend more time explaining what's going to happen after. I always start by saying, yes, it can be a bit confronting when you see your baby. Your baby will be asleep. Your baby will have tubes and lines and breathing tube and lots of material, which is already can be difficult to see for a parent. And then what would be the expectations in terms of when would their baby wake up? When would their baby be able to breathe on their own? Where would we be able to start removing the tubes, the lines, the catheters, the monitoring, and all of this? And how long will more or less be expected to stay in the hospital? So first in the intensive care unit and then in the hospital in general. A question that I am usually asked is, what's the usual recovery time? Personally always been very impressed on how quick the children recover after such a big operation. But yeah, it's very different from one child to another. It's very different from one operation to another. Yeah.
So there'd be a really big percentage of people or patients in that setting, parents with your patients, I should say, that this is their first time. So there's lots of questions and what to expect. So what does that look like when we come back for a subsequent surgery? So how does that look for you too? If we've gone on that journey before and we've handed over our little baby, and now that baby's 6, 7, 8 and requiring more surgery, how does that change the conversation? And is it the same expectations on the other side?
Yeah, I think what I try to explain to the parents is that, and I actually go through all the details as I would if it was a first operation, because it can be different, and I cannot assume that they know because they already went through that. Well, it was another experience actually. So, I take the risk to repeat myself and to state things that they already know, but I think it's still important. It's a different setting, it's a different operation, it's a different time. So yeah, I just go back to the basics.
Go back. And also too, I suppose also, this is such an overwhelming time that there might be things that maybe we've blocked or we've forgotten over time. So if I take it to another level of thinking, so, my son was operated on when he was 4 months old or 4.5 months old. If I skip forward now and I was to present to you for surgery again with him, is he in the room? Is he in the room when you're having this conversation? So it's mum, dad. And so are you breaking it down in a language that's suitable for that young person?
It really depends on the setting. It is a question that we ask ourselves and that we may ask the parents. Some parents are totally fine. Some children are eager to know.
To understand, yeah.
And I also don't assume that they shouldn't, know what's going to happen to them. So it's really adapting to the child and to the expectations. Yeah.
No, and I think it's something that I almost wanted to ask myself, because I sometimes wonder what that would look like. And I speak to other families or other parents, obviously, that
the Royal Children's Hospital is about to close for the night.
Sorry.
No, that's perfect. I'm not sure, Becky, I think that's a great outtake. Becky's on silent, but I reckon we just grab that. No. So we've talked about obviously what it looks like for your day, getting prepared for surgery. The one thing that I think a lot of people are probably wanting me to ask you is, what are you doing when you pick up that phone and you tell us, like, what are you telling me over the phone after you've come out of surgery? Because that's what we're all waiting for. We walk those halls, or we go and we look at meerkats and we do whatever we can to distract ourselves. That's obviously in your Melbourne, but we're waiting for that phone call. We're all waiting for that phone call.
Yes, and I know that. And so I think the only thing that you want to know is my child okay? That's the only thing you want to know. Well, being a parent, if my child was to go through that, that's the only thing I want to know. Is she alive? Is she well?
Yes.
So that's the first thing I say. I say, your child is okay. And then I did the operation as we talked about. I don't go into details. If I did something different for any reason, I say, I did this differently because of this. It's usually a very short phone call, and it's just saying, your child is good, it's gonna go to ICU, and also, giving a time frame, because when I leave theater and when I give that phone call, usually I give the phone call when the child is still in theater and when we are finishing up, and from that moment there's still at least 1 or 2 hours before the child is in ICU and ready, when the parents can actually see their child. So I also warn them that they don't have to rush to the hospital. They usually have time before they can come back. So, yeah.
I'm glad that you actually said that, because I think in that moment we hear that phone call and we want to rush. We want to rush back and see our baby. And I think it's lovely for people listening who haven't quite gone on the journey of surgery yet to know that phone call is you literally finished performing your piece, your magical piece, and picking up the phone and saying your baby is safe and successful. But it's not the end of the piece, is it?
Yeah, I usually take my gloves off, take my gown off, wash my hands, put my loops back into their case, and then go and give a phone call.
Literally.
Yeah.
Literally. And I appreciate that insight. So, Stephanie, if we can move out of your surgical world and we can move into sort of the research and the field of developments. So you touched on earlier surgery, I should say, not just pediatric cardiac surgery, but surgery around how it's linked closely to craft and needling and sutures and embroidery and all those sorts of things. So from your perspective, are there things that you've seen in your career that you've gone, gosh, that I didn't see that 10, 15 years ago, or when I was training, or gosh, like you've referred to earlier about your training and what training now looks like now. So what developments have you seen?
Yeah, a big change. So people are usually like, wow, this is amazing when we talk about robot and very fancy stuff. I must say, an enormous change that I've seen that had made a really big impact has been something that we call fast track or enhanced recovery programs. And I've seen it. So in the previous unit where I worked in France, I've seen it in the adults. It was impressive. You would perform exactly the same operation on, basically the same type of patients. But instead of spending a week in the hospital, very miserable, in pain, not moving, not being able to go to the toilets, not being able to eat normally, and in a very bad, mental sort of state, just by changing little things, but a lot of little things that surround the care of surgical cardiac patients, like, for example, lighter anesthesia, shorter times to being able to breathe on their own, trying to keep the drains, the little tubes that we leave in the chest after the operation, try to leave them as short time as possible. Try to making sure that, they can move around as soon as possible, etc., etc., and especially reduce the amount of opioids we are using, the pain medications, still being, sure that they are comfortable. The pain is well managed. But all these little adjustments make a huge difference. First, in the patient, well-being in general, but even we can quantify a reduction in complications like infection, lung infection. It's very amazing, and it's amazing that it's not revolutionary, like it's not robot and AI and very complicated stuff. It's small little things that put together, and it's a team effort, have a really big impact. And so we have started, it's been very well described in the adult world, a bit less in the pediatric world. And I think that's because the children are very resilient. They have a very different way of expressing their problems. And sometimes it's very difficult to identify that they're actually not well.
Okay.
They won't necessarily express it an adult that is not happy will be like that. Oh, yeah. Poo in 3 days. I'm very, grumpy. And well, children may not necessarily express that. They may, but they may not.
May not.
And yeah, so we have studied this at the Royal Children's Hospital, and so far everybody is very happy with the result. We are still at the beginning, and I'm waiting on having more, feedback, especially from the parents. And we haven't applied that to all cases, but we are broadening. And yeah, it's very nice to see the children being able to move around much faster, have less, complications related to the pain medication that can make them very nauseous or, yeah.
So it sounds like, how we talk about in life, what's the 1%? It's the 1% in life that you do this or you do that. It sounds like it's a myriad of 1% that have obviously created this huge impact and outcome. And that's exciting. Like, it's really nice to hear, like you said, that it's not always about the robot or technology, and basically bringing back to that really human-centered, that really holistic care of thinking, well, if we do this or we remove this sooner, does that actually affect the well-being or how someone feels or processes something long term? So yeah, it's incredibly fascinating to. And so that was that happening when you were first in the field, or is this fairly new?
It's fairly new, and no, it was not like that when I started my training. So yeah.
Yeah, okay. And so is there anything in that advancement space from a surgical perspective that's changing things?
Yeah, we try, surgically, like technically, we try now to do less invasive approaches. It means smaller incision, if we can try to have a smaller incision and try to reduce, in terms of techniques, what's going to be, but not in a way that, we need to rush. No, in a way that it's still going to be efficient. It's still going to be precise.
Effective.
It's going to be effective, but can we do it better? It's actually a very good reflection process, and it's a very good way of, why do we do that way? Oh, we have been doing that for 30 years and it works very well. Yeah, it works very well, but maybe we can even do better. And that's the whole purpose of research in general, and especially clinical research, is not staying rigid on your successes, but keep asking questions and keep the main question that we keep asking, can we do better? Can we improve the outcomes for our patients? So yes, I mean, there are other very exciting fields of research that would involve more sophisticated things, I would say. And I'm also very, excited about that. I think one thing that I find very interesting, it's the use of data in healthcare in general, and especially in, cardiac surgery. And it's incredible that, you are giving your data away all the time when you're on social media, when you go on Spotify, on Netflix. You may not remember it, but you actually tick that box that you say, yeah, I'm giving away all my data and you can do whatever you want with it. And there are so many people working on that and using that for business purposes. And I'm like, why don't we do that for health? And
for health.
We can have access to so much data. Why don't we use it? Why don't we have, an army of people like in Facebook and all the megas to work on that and to try and find answers to the, to the surgical world, and answers to, how can we improve? How can we do better? How can we achieve better outcomes? Maybe someday we'll be, how can we avoid surgery? Do we have another?
Is there another way? Is there another intervention?
Yeah.
But I love that you even just referred to data that way, that, hang on a minute, we use our data every day. Spotify grabs it, Meta grabs it. Sorry, why aren't we applying this to health? And I suppose that's where all those beautiful disruptive practices come about, don't they? Is because you apply something that's being used in another industry and you apply it to an industry that, in your point, is why? Why not? Why we do it this way. It's more like, why not? So it's a beautiful way for us to actually acknowledge and wrap up this podcast with you, because we're incredibly grateful for your time, incredibly grateful. If you could share with us your reflections on your career or your day, and what's the most rewarding part, or what would you like to see in the future? I'd love you to share it with our audience.
The most rewarding part for me is when in the morning between rounds I'm going to theater, I go down and I get my coffee and I see a child that's, but this is the child we did this operation.
Oh, how special.
Doing so well.
Oh,
this is the best. For me, it's really the best. To, it just gives me sense and purpose, and that's all I need. That's all we need, right?
That's all we need.
And it's really priceless to see that, you actually contribute to have someone living a life and having a life. So it's there's nothing better than that. In terms of, what I expect, I just think we have a lot of work ahead, as I said, to try to improve outcomes and, try to get children to be better in the most painless and most comfortable way. Yeah, I dream someday maybe I'm just useless. There's no more heart disease. We found a way to avoid them to ever happen, or we have a pill that just closes holes within the heart, and maybe one day it will happen and I will have no more work to do and I can retire.
That's beautiful. If I could sum up this conversation with you, it started with magic and it's ended with magic. I love the fact that you were inspired to become a cardiac surgeon because you thought the heart was magical. I love the fact that you play a part in those magical outcomes, like you say, play that small part in seeing that life. And yes, let's hope that one day there's a magic pill that closes over that heart. So thank you so very much, Stephanie. We've taken up your time and we appreciate you need to get home to your little one.
Thank you, Sami. It was very nice.
Sometimes this podcast talks about some heavy things. If this brings up anything for you or someone you love, it is important to reach out for support. The Heart Kids Helpline provides support and guidance for anyone impacted by CHD. You can call the helpline on 1800 432 785. To access more information about CHD, as well as support from Heart Kids, visit the website at heartkids.org.au. The information on this podcast is not a substitute for medical advice from your doctor or healthcare team. Always talk to your doctor about matters that affect you or your family's health.